Meeting to order of the Senate Appropriations Community Health Subcommittee. Appreciate everyone being here bright and early on Monday morning after daylight savings time. I mean, that's punishment, isn't it?
We voted to do away with that, didn't we?
We did. We did. Senate was strong on that issue.
Mm-hmm.
All right.
Did a lot of good.
Exactly. Chairman Strickland, if you would, give us a word of thanks.
Good morning. If y'all please bow with me. God, thank you for this day, and Lord, thank you for the ability to serve the people of this state. Lord, please guide us and lead us throughout the day and throughout this week, and keep us safe as we travel as well. In Jesus' name I pray. Amen.
Thank you, sir. Again, appreciate everyone being here. I think Commissioner of Community Health is on the front row and ready to go. Thank y'all. I've asked those presenting to mainly focus on the House changes, but obviously members can delve into anything they feel moved to do so. You want to introduce your team and get started? Thank you.
Absolutely. Good morning, Mr. Chairman, members of the committee. Kaylee Noggle, Commissioner in the Department of Community Health. This is Rich Kim, our Budget Director. We also have other members of our team, Ryan Loke, our Chief Health Policy Officer, Joe Hood, I believe, is here, our Senior Advisor, and Brandy Sylvan and Caitlin Ward from our Government Relations team are with us as well. I'm basically going to walk you through your tracking sheet and focus on the changes. There's a number of changes and also a number of new items. So I'll kind of refresh your memory on a couple of things that we discussed during the joint budget, and then spend a few minutes talking about some of the newer items. Starting in our departmental administration program at 84.7, increased funds to replace the Medicaid Information System, our MMIS, with the Medicaid Enterprise System Transformation System, an increase of $6.5 million. There was an add in our amended 22 budget to support this. You may recall we mentioned during the joint budget hearing that federal CMS is requiring all state Medicaid systems to undergo a transformation, basically replacing our current Medicaid systems with new modular-based systems. So we'll go through a number of procurements between now and our go-live projection of sometime in FY25 or 26. This add of $6.5 million will support our provider module, our claims module, and our system integrator, which will be the piece that sits on top that will combine the data from all these different modules, and we'll have another number of other modules coming down the line in future years. At 84.8, increased funds for the Enterprise Analytics Solution for Everyone Data Warehouse. This is another module within that MEST project for $424,000. Right now, all of our Medicaid data actually sits in a third party's data warehouse off-site. For us to run new reports or new data analytics, we have to go through that vendor and write new procedures and new scripts to get that done. This will bring all of that information in-house so that we can be a little bit more dynamic and flexible in our reporting and data analytics capability, which is what we're trying to do. 84.9 is $1 million to increase funds for a study on reimbursement rates for mental health care providers. This is a provision that's included in House Bill 1013, or the mental health bill. And 84.10 is another item from 1013. The department shall begin preparation for repository for tracking, analyzing, and reporting information from complaints received by consumers and healthcare entities related to healthcare parity violations. And that's just a yes item. There are no changes in the Georgia Board of Dentistry or the Georgia Board of Pharmacy, so we'll skip over to healthcare access and improvement. Changes start at line 87.5. First, there's a reduction of $500,000 to eliminate funds for one-time startup funding for two FQHCs. I think those funds were added in FY22 and supported Marion and Jeff Davis FQHCs. At 87.6, there's an increase of $500,000 to support behavioral health expansions at two other FQHCs at Coastal Community Health Services and South Central Primary. 87.7, $74,000 increase to fund mental health first aid training to address the need for frontline workers. This will be funded through area health education centers. I believe there are 6 of those around the state, managed through Augusta University. This will be a little bit of one-time funding and training for instructors, and then to spread those funds between those 6 different locations. Similarly, at 87.8, increased funds to expand the RN reentry program. This is also a program that's managed through the AHEC, so these are grant funds given out through our Health Care Access and Improvement Office to the AHECs. The RN reentry program is a program that trains and sends nurses that have licenses that have potentially lapsed or that have been out of service for a while to come back into the nursing field. In healthcare facility regulation, there's one change at 88.4. It's a reduction of $3.7 million. There was a reduction similar in our amended budget. This is really essentially based on what we probably truly can spend in the program. I don't anticipate any issues with that reduction, although we'll come back to you if we see like we can suddenly staff up in FY23 and run out of money. That would be a great issue to have. No changes in the Indigent Care Trust Fund. In Medicaid, age blind and disabled, there are a lot of changes, so we'll take a few minutes to walk through some of these. Starting at 90.1, there's a decrease in funds for growth in Medicaid based on projected need, a decrease of about $4.5 million down to $12.3 million. This is essentially just later data based on the House projections. At 90.2, $74.6 million was added in the governor's budget recommendation, was to reflect the loss of FMAP. That has been zeroed out as we expect the public health emergency at the federal level to last at least until mid-July. Because it will last until mid-July, that means we'll get another quarter of enhanced FMAP from the Fed, so it reduces the need for state dollars, and you'll see that in a couple of other programs as well. At 90.6, a reduction in funds to reflect an update to the 2019 RS Means Index for nursing facilities. The governor's recommendation was a reduction of $638,000. The House reduced that reduction to $380,000. That's really just based on a calculation and methodology change that we worked with the House and OPB to correct. At 90.10, $498,000, an increase in funds for a 10% reimbursement rate for long-term acute care and inpatient rehabilitation facilities. That should impact about 16 facilities statewide, providing a 10% rate increase for those facilities. 90.11, reduce funds for skilled nursing centers to reflect the 2020 cost reports of $6.1 million. As you may recall, we're currently in FY22 working off the 2019 cost reports with an additional increase separated out for GLPL, or general liability and professional liability. In FY23, the budget is proposing that we go back to a consolidated cost report for all nursing home facilities using the 2020 cost reports. Next, at 90.12, increased funds for a 5% reimbursement rate for mechanical ventilators of $424,000. There's about 185 of these beds across the state in 9 different nursing homes, so this will provide a 5% rate increase for those facilities as well. Another new add of $1.9 million to increase funds for the reimbursement rate for home and community-based services to offset the cost of fingerprint requirements. Fingerprint requirements for these facilities started from SB 406 back in 2018. And so we'll increase the rate as much as we possibly can within that $1.9 million to help offset those costs. Increased funds to increase reimbursement rates for medical nutrition therapy, $10,600. There's 3 or 4 different reimbursement codes related to nutrition counseling and nutrition therapy that are used for lifestyle and nutrition counseling and coaching for certain conditions such as diabetes and certain heart conditions. 90.15 is a 10% increase for about 17 different dental codes, a couple of extraction codes, and then dental restoration codes for $179,000 increase in that. You'll see some of these items in LIM as well as PeachCare. Moving into LIM at 91.1, low-income Medicaid, again, a reduction of $20.8 million that was included in the governor's budget for based on projected need. Again, just later data based on House projections. 91.2 is again the reduction of FMAP, since those increased FMAP funds should last for the first quarter of FY23. And then jumping down to 91.13, an increase of $4.5 million. Increase funds and direct the department to submit an 1115 waiver to provide Medicaid benefits to individuals with HIV. The fiscal note that accompanies House Bill 1192 estimated that cost to be about $18 million in state funds, but based on the timing of how long it would take the department to prepare, submit, and get CMS approval, this is really about 1 quarter, assuming that it would go live probably around next spring, March or April. 91.14, again, similar, $259,000 to increase those reimbursement rates for medical nutrition therapy services. $498,000 for those same dental extraction and dental restorative codes. At 91.16, $1.2 million increase in funds and a direction to the department to submit an 1115 waiver to remove the 5-year waiting period for Medicaid coverage for lawful permanent residents. We actually believe that after a little bit of research that we might be able to do this with a state plan amendment, which would give us a little bit more flexibility and timing. As budgeted here at 1.2, that would again assume that we started next March or April, but potentially we could start that a little bit earlier, but can keep it there as well. At 91.17, an increase of $825,000 to increase about 4 different reimbursement codes for OBGYN services, really to keep the OBGYN providers in line and in parity with the primary doctors that are receiving some additional rate increases related to the attestation increase that we've talked about a couple of times. And then at 91.18, $5.7 million to increase funds for value-based purchasing. This was something that was discussed during our amended budget. This is a portion of what we would need to do this. The total state funding required to implement value-based purchasing is about $49 million. The way this works is that in order for us to implement that program, we need to raise our capitation payments to the CMOs to a level that even if we withhold money based on quality, the base or the bottom, the lowest amount of the payments that they could get would still be actuarially sound. So in order to do that, we would need to add funds to increase their payments, then to be able to have some flexibility to design a quality program where we were then taking funds away. In PeachCare, first change is at 92.2. Again, it's a similar reduction, the $624,000 that was zeroed out just based on the enhanced FMAP extending into FY23. At 92.4, $11,476 for those same medical nutrition therapy codes, $8,142 for those same dental restorative codes, and $310,000 at 92.6 increase for the same value-based purchasing that would apply to PeachCare as well. In total, the House budget is a reduction of $153.9 million. Most of that from the extension of the FMAP into FY23, but a lot of the savings have been shifted into new initiatives and new Medicaid benefits for our members. Happy to answer any questions. There's a lot in there. We'll see if we can't do our best to answer your questions or get back to you if we can't.
All right, thank you.
Thank you for your very clear presentation, Commissioner.
Thank you.
Just going back to 87.7, I just wanted to point out on the mental health first aid training that we had a study committee last year on violence against healthcare workers, and one of the things we came up with was a one-day course that's been developed with GIPSTIC and the National Association of Mental Illness that is available for low cost to healthcare workers. And if you want the information about that, I'd be happy to send it to you because I think that might be something we could work together on.
Absolutely, we appreciate that.
That was all. All right, Chairman Watson.
Yeah, appreciate that. Thank you, Mr. Chairman. Appreciate that. The 91.13, the 1115 waiver for Medicaid with Medicaid patients with HIV, and 91.16. Can you just help clarify for me? So the bill that's come over from the House, 91.13, that allows that, or can you just clarify that a little bit for me?
I need to double check with Brandy. I don't know that has crossed over yet. She believes it has.
It has.
There is a.
It's in Senate HHS.
1192?
I don't know the number. I do know the thought process. 1115 waiver for Medicaid benefits for HIV.
There's a fiscal note on that. So essentially, right now, and Ryan will tell me if I'm wrong, but there are no Medicaid benefits for anyone other, essentially in LIM, other than low-income moms, pregnant women, and children. This would extend benefits to anyone in Georgia that's uninsured with early HIV diagnosis and provide that coverage during the first year or two of their diagnosis, up to essentially, I think, is drafted 138% of federal poverty level. And we have the flexibility. There is an option to do that through an 1115 waiver.
I think the idea is to reimburse those expensive medications to keep them asymptomatic and viral free. So the only ones covered now would be those that were disabled by end-stage disease, which doesn't help us a whole lot. Very expensive. I've got a few questions. The new Medicaid system and the MEST, what will we see when that does go live from the standpoint of the provider in the state and other folks that interact with Medicaid? I mean, can you give me just a 100,000-foot level of what we're supposed to get out of that large investment?
Yeah, for sure. Certainly it should be a more seamless process from provider enrollment to Medicaid member enrollment and claims processing through our EV&V system and on through third-party liability and so on and so forth. The idea behind this is that instead of having one kind of monolithic system that does so many things, is that it's built in modules so that we can, if something's not working, that we can take one piece out and put another piece in fairly painlessly. Or my IT guys might disagree, but more easily than it can be done now. And that it's also a much more competitive process for us to build a system in these different components, but ultimately it should allow us to have our data flowing in and out of the system through these different providers in a much more seamless manner. And then with the combination of our new data warehouse, allow us to do a lot more, which y'all have heard me talk about, data analytics and reporting, and using those analytics to move further into insights on how we can use the information to better cater our policies and Medicaid program to different, to provide different services in different manners and bring you those recommendations.
Are other states ahead of us in this implementation, or is everybody about the same?
If anything, we're a little bit ahead of the curve. We have executed contracts on provider. I think we're very close on the claims module. We're working through some national organizations and leading the effort on a couple of those procurements. We anticipate hopefully go live sometime in FY23, where we would then bring down the old system and stand this one up in its place singularly. And ultimately, we're hopeful that it would save some money.
Okay. I guess the final question on that area is do your folks feel like this is actually, going to work? Is it?
Yeah, I think they have worked this year through probably the trickiest part is not the individual models, but probably the system integrator, which is the piece that has to sit on top and then flow data in from all these different sources and put it back out into these systems, which start in different file formats in and out. They are working with GTRI to develop that system. Once that is up and running and stable, then it will be handed over to somebody else for ongoing maintenance and operations. But once that hurdle, and we're pretty close on that, I think, in getting a really good system integrator developed, they feel like it is doable, and that we should have a lot more flexibility and be much more nimble with claims processing and our data once that piece gets up and once the full implementation launches in 25.
I guess the biggest, as you mentioned, dollar amount change in there is the PHE adjustment for FMAP. If you would let the committee know what y'all's crystal ball suggests that might be, and what will that challenge be, I guess, from a budgetary standpoint when that switch is flipped?
Sure. So We are pretty confident that the PHE will last until mid-July at least, giving us that extra quarter. Nothing is official, nothing's in writing, but CMS and folks are starting to talk potentially one other short extension, maybe through end of July, very early August, but at which point there's some early anticipation that that's when the federal public health emergency would end. Shortly after that, sometime this fall, we would start redetermination of Medicaid eligibility for all the renewals that have been paused during that time. We're upwards of 2.6 million Medicaid members now. I think our budget projections assume that a large number of those would be redetermined and start rolling off over the course of the next 12 months. It'll take us at least a year to redetermine everyone in conjunction with our partners at DHS and DFACS that do that work with us. Budgetarily, we are budgeted as though the FMAP is going away. So even at that still sustained high level number of Medicaid members, we're budgeted to account for that. But there will be some right sizing of the population over the course of the next 12 to 18 or even two years as we see members roll off, to be determined what happens within the ABD population and SSI. So there'll be a little bit of fluctuation over the next year and a half or so as we kind of get back to whatever a new normal is going to look like.
The medical nutrition program, if you could get your folks to get me whatever's information, some background on that, just
Sure.
so
We've got some
make
numbers
sure
for
all my members know what that's for. And the other waiver, you're saying if you are able to do a plan amendment, implementation may be quicker. Is it normally that would mean it needs to cost more since
That's
we're starting it early? So do you have some data on what you think that new estimate could be for? And you may have already given that to
Yep, we can get it to Keith. Yep.
to Keith.
Yeah, we have a pretty good idea of the number of folks that have been previously denied for Medicaid eligibility before that, so we kind of know who's waiting in the wings that would immediately become eligible, and then it would just be the additional months of people applying that would have a different eligibility criteria going forward.
And I guess the last question I have is on the value-based purchase and the 49 million, and from the again same issue with implementation. Just make sure we get the details on what you think is a reasonable
Sure.
implementation and what that would look like. Anybody else have any questions for the commissioner or her able staff? All right, thank you.
Thank you.
Appreciate y'all being here. All right, next on our list is the Georgia Board of Healthcare Workforce. Director, if you'd introduce your team to our members.
Yes, good morning, Mr. Chairman and Senate committee members. My name is Freeman Montague. I am the current interim executive director for the healthcare workforce. I mentioned this last time, but just to reiterate, of course, I'm essentially filling in for our previous executive director who tragically died suddenly. So in addition to an interim executive director, I'm also the budget manager. So it's not quite the same as being executive director of two boards at the same time as Ms. Hughes, but it is wearing multiple hats. And this is our outreach coordinator, Abrielle Beckham. She is fairly new, so if you have any hard questions, you can ask her instead of me. But thank you. So I'm actually, if you don't mind, there was quite a bit added in from this Friday. I'm just going to focus on the new items, and on your sheets, those are going to be the ones that have the red next to them. So we can actually, you can go to the next slide. I'm just going to start with 94.4. And I would also say, before I get too deep into this, again, there were several new items that were added. Some of this, we're still trying to confirm more details on what there is. But anything that I have some information for, when I actually go through the items, I'll try to give you details then. So Starting with 94.4, that's to increase funds to implement a behavioral health care workforce database. That's the only new item for admin, and that is for $400,000. So this is based on essentially a guesstimate, an estimate that our data team provided to us on what they think the cost of that would be. The breakdown, if you want a little bit more detail, is they believe this would require hiring a new person to the staff for possibly $50,000 plus fringe. A lot of this is information that they researched on other databases, so it's just kind of, I think, a worst case scenario. For the database and dashboard creation, the estimate that they researched showed it to be between $100,000 to $200,000 for that item alone. And so just, again, worst case scenario, if it was $200,000, we had that number. Database annual maintenance, they believe, would be around $68,000. And so all of that combined is a little bit over $318,000. They also mentioned that there would need to be an item to ensure access for law enforcement. That is something that at the time when this estimate came out, they were not sure, and as of right now, they're still not completely sure what that amount would be. So with about $320,000, whatever the cost would be for law enforcement, possibly any more, funds needed for staff or anything like that, $400,000 to them seems like a pretty decent estimate. Thank you. Next slide. So moving on to our graduate medical education, this is where quite a bit of our increases went in. So I'm going to just start again with the new item, which is 95.2. So it's not so much new, so much as it's been altered. We had always had a request for new slot funding. Originally, it had been for 136 new residents, and I believe it was for about $2.5 million. The new request is for 199 new residency slots for about 3.9, so almost $4 million. And this comes from the information Ms. Hughes had been working with Denise Cornegay and the Primary Care Summit on. For FY21, we actually did not have any new slot funding at all for GME, and this request takes into account those slots that we did not fund for FY21. So essentially, it would bring us whole. We're essentially almost like lagging behind a year in slots. If somebody had asked for 3 slots in FY21 and 3 more in FY22, they would have 6 total. But because we didn't fund for FY21, we would just have 3. So this would basically keep us on track with where those institutions are. 95.3 was to increase funds for a pilot program. I believe this was for the Medical College of Georgia for their ectograms and for addressing maternal mortality. That has been removed from our budget and will go into Department of Public Health. These next few items are also for Medical College of Georgia up until 95.7, 95.4 to increase funds to support, I'm sorry, not this one. This is for Archbold Medical Center. That is for $350,000. 95.5 is to increase funds for a fellowship position at Augusta University for gynecologic oncology, public health focused medicine, and rural primary care. That's $375,000. 95.6 to increase funds for one-time funding for statewide dental workforce assessment to evaluate current and future needs for $35,000. 95.7 to increase funds and utilize existing funds for $150,000 already in. For Southern Regional Medical Center for continued planning and startup of a new residency program, that is for $50,000. And 95.8 increase funds and utilize existing funds for $150,000 for Southeast Georgia Health Systems for continued planning and startup of a new residency program, also $50,000. So from 95.4 to 95.8, those are some of the newer items that we don't have a lot of detailed information on currently, but we are corresponding with the best points of contact to see if we can get the information. And of course, when we do, we will notify the committee of that. And 95.9 is to increase funds for capitation funding for 7 residency slots at Emory University. This is for 2 OBGYNs, 1 psychiatrist, and 4 in internal medicine, and that is for $109,323,000. And so the program net for GME would be $5,369,858. All right, next slide. Moving on to Mercer School of Medicine. The only new addition that the House recommended was 96.2. That's to increase funds and utilize existing funds. $500,000 to expand the accelerated track program to include forensic pathology. Mercer had initially been given $500,000, I believe, for this current fiscal year to fill that position, but they had relayed that they were having difficulty finding anyone for, or I think it was 2 people for that position. So I think this is just reflecting what may be more pragmatic for them at the time. Moving on to Mercer, and I think there is a representative from Mercer here, so if I get some of this wrong, they can help fill me in on some of these requests. But they had 97.1, increased funds for the startup and operations support for a new nursing program in Mercer School of Medicine. That is for $2 million. This is a startup for the operating support for the nursing program.
Let me interrupt. That's Morehouse. Morehouse, not Mercer.
Oh, I'm sorry.
97.1 is in the Morehouse.
Okay, yes, I'm sorry. All right, so 97.1 is to increase funds for the startup and operations support for the new nursing program at Mercer School of Medicine. And 97.2 is to increase funds to support child and adolescent psychology and psychiatric residency programs. And that is for $375,000. And so I believe the $2 million was to help for the startup of operating system for, I believe it was for 20 students that they believe would come on board for FY23. For $376,000 for 97.2, I believe that was broken up into 2 different pockets. One was for $240,000, and that was for Child and Adolescent Psychology Fellowship Program to support 4 residents. And then the additional $136,000 was for the Psychiatry GME program to provide capitation funding for 9 residents. And 98.1, the new item was to increase funds for additional loan payment grants for physicians, physician assistants, and advanced practice registered nurses. That should be for 7 physicians, which would be $25,000 each. 1 physician assistant, which would be $10,000, and 20 nurse practitioners, which would be $10,000 each. And that would come to $385,000, and that is the program net for physicians for rural areas. And the last item would be for 99.1 for undergraduate medical education. That's to increase funds for the Philadelphia College of Osteopathic Medicine for South Georgia's campus to support new growth for that program. That is for $375,000. I don't have many details for that, but I believe there is a representative here just in case there are any questions about that I might not be able to answer for you today. And on the last slide, just to show from the original governor's recommendation for FY23, there was a little bit over $10 million added to the healthcare workforce budget, and that is for a total of $100,450,808.
Okay, thank you for that. Chairman Kirkpatrick.
Thank you. I just had a question about the GME part of your budget. As you know, we've got a bill that's pending, Senate Bill 340, that's crossed over to the House side now, that changes the size. It takes away the size limit for residency programs. And I just wondered if the new funds that you have in here for these residency slots contemplated that bill, or you think you're going to need something additional?
The last time I checked on this, it should not affect the bill. the funding that we would have for that. Assuming these would go into effect for FY23, then that should be fine. I think if there was anything that went into effect a little bit before that, there was one institution, I think it was Hamilton, that it may need to, it may be affected.
Anybody else with any questions? Y'all gonna let him off this easy? All right. Appreciate what you're doing. I know it's been a challenge, and we appreciate the work. And I know we'll have some further questions as we go through the process, and I know we can look for y'all to get back with us as soon as possible. Thank y'all for being here.
Thank you.
Georgia Drugs and Narcotics. Okay. I don't have any. Yeah. Okay. All right. Welcome.
Good morning, Mr. Chairman.
Director.
Thank you for having me over. My name is Dennis Trofton. I'm the director of the Georgia Drugs and Narcotics Agency, and that's essentially the law enforcement and regulatory enforcement for the Georgia Board of Pharmacy, but we are a separate agency. I apologize, I don't have mine's a very quick and small changes, so I don't have a presentation to put up on screen for you. The only changes to our budget that came over from the House, and it's line 101.4.
So let me interrupt just a
Yes,
minute. Just let everybody have time to get to the tracking sheet. It's the last agency in your document, and the House change is 101.4, right?
Yes, sir.
Is everybody good? Okay, go ahead. I'm sorry.
No, I should have had you a nice slide up there. I apologize for that. Increased funds for data management system to track license, complaints, inspections, investigations. At this point in time, our agency does not have a data management system other than one we've put together ourselves. So this is something that we feel like would certainly make us more efficient, certainly be able to draw numbers and do analysis of data much better than we do at the moment. And again, that's really an IT issue for us. So this would get a data management system formulated just for us, and we're unusual because we do not only law enforcement, but the regulatory enforcement. So that's really two different hats and two completely different tracking systems and types of tracking systems. So that certainly would be advantageous for us to have that system. The recurring cost, that first cost for this year would include the getting the system in. So the recurring annual cost for this for that system would actually be probably about $100,000 less, and it would include one person in the system, and then the recurring cost again would be about $100,000 a year less. But so for this particular budget cycle, the 214-26, then we've got 101.5, which is would increase funds for 2 additional agents. We have 10 agents now, 10 full-time slots. We've recently had an agent that left us in Southwest Georgia, but working to fill that. So this would be 2 additional agents. Unusual for most law enforcement, our agents, as myself. I've been a pharmacist for 30 plus years and been a law enforcement officer for 20 plus years, and all of our agents by statute are required to be pharmacists and to maintain their pharmacy licenses and to maintain our post certification. So it's a unique group we have, and so this would increase the workforce to 12 agents on the street doing the facility inspections and visits, et cetera. And that's only changes for us.
All right, thank you. Anybody have any questions on committee? All right. Thank you, sir, for being here.
I hope my day goes that quick and smooth.
Well, the Senate's quite, we're very kind over here on our side now.
Amen. Thank y'all.
And I appreciate the summary for the members. That's helpful. I do think your agency's fairly unique, and we appreciate the work y'all are doing to keep us safe. Thank you. All right, Director Thomas. Director Montague, one quick thing that I forgot to mention to you. If you would get with Keith on the loan amount that's in the base, and so how much of a percentage that's a bump up, if you would get that for us. All right, thanks. All right.
All right. Thank you,
Director.
Chairman Burke and members of the committee. Grant Thomas, Director of the Office of Health Strategy and Coordination. I'm honored to join you all today to discuss the proposed budget for the Office of Health Strategy and Coordination for fiscal year 2023. Just wanted to start off by providing a brief history of the office and its priorities for those of you who may not be familiar with us, as we're a new office in state government, and then I'll get into the specific line items in the budget and House additions to OHSC's FY23 budget. So OHSC currently operates within the Office of the Governor and is housed within the Governor's Office of Planning and Budget. OHSC was established through House Bill 186 during the 2019 legislative session in order to strengthen and support healthcare infrastructure of the state, interconnecting health functions and sharing resources across multiple agencies, and overcoming barriers in the coordination of healthcare. The purpose of OHSC is to ensure that the healthcare issues of greatest concern of the state are identified and that the appropriate stakeholders are brought to work on these issues. The powers and duties of the office include facilitating coordination and collaboration among the state's state health agencies, coordinating state health functions and programs, serving as a forum for Georgia's specific health issues of greatest concern, and promoting cooperation from both public and private agencies to test new and innovative ideas. Governor Kemp appointed me to this role to serve as director in June of 2021, following the office being funded for the first time in the FY 2022 budget. Since then, I've worked to fully staff OHSC and begun working on the office's main priorities, working alongside our agency partners and outside stakeholders to address the pressing healthcare issues in the state. Our team is currently staffed by 4 full-time staffers, including myself, a deputy director, legal counsel, and a policy advisor. We also employ 2 contract employees to assist with our APCD project, as well as some work on to analyze quality payments for skilled nursing facilities. Our office also advises the governor's office on healthcare policy issues. We also have several key initiatives and projects underway, working with state agency partners on numerous children's healthcare issues, including recommendations for the proposed community action treatment teams, models for improved care coordination, provision of autism services, and children's mental health. Additionally, we've worked on initiatives to address maternal mortality, skilled nursing facility quality payments, like I mentioned, the opioid epidemic, and healthcare workforce issues. We're excited to continue working on all of these issues and others as we move forward. Getting into the fiscal year 2023 budget, as I mentioned, OHSC is our budget is currently included in OPB's budget for fiscal year 2022. And we've operated within OPB. If you turn to page 20 of the Senate tracking sheet, line item 171.99 creates a new program and purpose statement in the budget for OHSC. In line item 171.98, you will see that OHSC's operating budget of $1,036,814 has been transferred from OPB to the new OHSC program budget. This funding covers our staffing costs, project management costs, and contracted services. Now, if you turn to page 19 of the Senate tracking sheet, line item 171.1 recognizes $800,000 in the base budget at the Department of Community Health for the all-payer claims database project that OHSC directs and manages through an MOU between DCH and OPB OHSC. For those of you not familiar with the APCD project, happy to provide a brief overview and background of the APCD and OHSC's role leading this project. During the 2020 legislative session, legislation was passed and signed into law directing OHSC to create and implement the All-Payer Claims Database. The APCD will be a repository of healthcare claims from both private and public payers that allows consumers and policymakers to better understand and compare healthcare costs across the state. It'll be able to promote cost and quality transparency, assess geographic variations in price and utilization, track healthcare spending drivers and trends, and promote public health. Being able to see and analyze actual healthcare costs and payments will allow the state to better make projections regarding Medicaid, PeachCare, the state health benefit plan, and those programs, and provide additional insight as well into Medicare and commercial payers. Other prevalent use cases include quality measures, avoidable emergency department usage, opioid prescriptions, prescription drug spending, and surprise billing. The statute directs the APCD to be operational by 2023, so we're working on an aggressive timeline. We worked over the summer and fall to bring on additional staff and a project management team, and we've also held 2 meetings of the APCD Advisory Committee. We also have several work groups underway preparing for implementation related to technical design review, use cases, how this data will be used, and then the data privacy and security and access to ensure that the data that we collect is secure. We've also partnered with the Georgia Tech Research Institute Center for Health Analytics and Informatics, which serves as the administrator of the APCD. They will assist us with data analytics, reporting, and data use agreements and submissions. We're also planning in the coming weeks to bring on an APCD software supplier, which will help us build the APCD and bring on a vendor with expertise who's done this in other states. The FY23 expenses include funds for project management team, the administration costs for GTRI, and an APCD collection software supplier vendor. We plan to continue to access this funding through our existing MOU with DCH. Now, if you turn to line item 171.3, the House has added budget language that directs OHSC to create and maintain a publicly available annual consumer report of hospital financing data pursuant to House Bill 186. So as you recall, House Bill 186 in 2019 increased reporting requirements for hospitals to increase transparency of their financial and operational information. Hospitals are currently reporting this information that's required in statute through the annual hospital survey, annual financial survey, and Form 990. However, this information is not currently available in an aggregate, consolidated form, allowing for comparisons to be easily made between hospitals. And so through this budget language, OHSC would continue to consolidate this information and work towards developing efficient reporting methods for this information. To that end, we're working with the Georgia Data Analytics Center to consider how this information could be presented. In line item 171.2, the House has recommended funding for 1 new analyst position to coordinate the collection and reporting of nursing and hospital data. This position would facilitate the reporting of that hospital information I just mentioned, as well as coordinating the collection and reporting of nursing data. So the Board of Nursing and the Secretary of State's office currently track workforce demographics and data from nurses who renew their licenses on an individual basis. The board also collects data reported by nursing schools. And so this analyst would be collecting and aggregating data that the state already receives on nursing workforce trends as well as nursing programs. And then once we collect this data from those state entities already collecting it, we can work to report the data in an aggregated and consolidated form, allowing for the state and other stakeholders to better understand and conduct analysis on trends and inform how the state will address nursing workforce issues. So this concludes our fiscal year 2023 House budget recommendations. I'm happy to take any questions if there are any.
Thank you, Director. Chairman Kirkpatrick.
Thank you for your presentation. You've been very busy.
Absolutely.
My question, I think you mentioned this, but based on work that's been done over the last few years on transparency and coordination of data between the agencies, the new platform, georgiadata.org,
Yep.
was introduced. And I'm just trying to understand the relationship between that and what you're doing, and are you working together?
Yes, so we work very closely. I believe you're referring to the Georgia Data Analytics Center at OPB, GDAC. So we work very closely with them. GDAC's mission is to take data that the state is already reporting and provide it in a consumable, transparent form for the public. And I think the idea through some of this information we'd be collecting on nursing workforce data and hospital transparency data would be to work with them and coordinate, which we're already doing, so that they can create dashboards. They have a public-facing website, so we can really leverage a lot of the resources that GDAC already has to accomplish a lot of this work.
Who, 13, is that?
Thank you, Mr.
Senator
Chair.
Wright, go ahead.
Thank you for being with us. I had two questions. Number one, does any of your mission and work underway look at healthcare in the correction system?
Yes, so we have done a little work, with looking at the correction system. I think there's a lot of opportunity looking at mental health care, how we can better coordinate and facilitate provision of services with mental health care and the criminal justice system, given that, there's no current state entity that currently looks at, how it impacts, all state agencies and all stakeholders. I think there's opportunity for us to continue, working to, coordinate mental health with the Department of Corrections. And I think some of the provisions in House Bill 1013 would charge us as well with coordinating mental health care with corrections.
With corrections?
Yes. Yep. That's a provision in that bill.
Because we've become accustomed to headlines that come and go around conditions in corrections, and of course I don't expect you to be a corrections expert, but
Yeah.
but the health, the interface with the health issues that seem to abound in the health services for inmates are concerning, and I wondered about that. And number two, do at any point with the vast array of tasks that you're undertaking and the scope of the mission, do you is Medicaid expansion just off the table, taking the federal funds that are on the table and putting them in, getting them into Georgia to fund expanding the coverage that Medicaid offers here?
Yeah, so with the governor's waiver programs, Georgia Pathways and Georgia Access, that was the administration's approach to expanding access to these populations. And we've already seen tremendous success with the Georgia Access program for this current plan year, which, some of those who are covered in the federal poverty level percentages, 100 to 138 FPL, are already seeing, they basically get health insurance for free right now in the individual market. So, and premiums have decreased by 12% statewide. The number of carriers in the market has increased from 4 to 11 since Governor Kemp took office, and the number of counties with only one insurer has decreased from 8 to 1. So we're already seeing a lot of, substantial impact, from those waiver programs. Unfortunately, the Georgia Pathways program is currently on hold due to a decision by CMS at the federal level, but we're hoping that that waiver, as the court and legal process plays out, that we'll be able to, start operations on that again. Because I think what we've done with the two waivers is a very efficient, responsible way to expand coverage to these populations.
I wish.
Yeah.
No, we're have a hard stop. There's another committee meeting that has to stop, but I'm sure Mr. Thomas will be available for other questions because his role has grown from nothing to a lot in less than a year. Yeah, absolutely. And I did want to bring out to the committee that having been reviewing House Bill 1013, his agency or area in government would probably quadruple if all of those pieces and parts were implemented. So I have asked him to start reviewing that and letting us know what from a budgetary standpoint, depending on that final outcome of that bill, what effect it would have, so we can be somewhat prepared for the 23 cycle. So good luck with that.
Thank you.
All right, thank y'all for your attention, and we're adjourned.